So it's a great privilege to be here. Thank you very much for the invitation to talk to you on behalf of the Reduce MRSA team as an example of how a health system and academic partnership can be very successful. The Reduce MRSA trial is a trial that involves the use of intensive care units to try to understand what is the best strategy for reducing healthcare-associated infections, particularly a notable one due to methicillin-resistant Staph aureus. And I don't have the clicker. So some disclosures is that the Reduce MRSA team is now embarking on a second trial, and in that trial we are accepting contributed product for participating hospitals. So this particular trial, the rationale is that healthcare-associated infections are one of the top 10 causes of U.S. deaths, and it is quite notably to be maybe one of the most preventable. And Staph aureus is actually the #1 healthcare-associated pathogen, and its dominant form is actually a resistant superbug. And there's been quite a bit of debate in the field for well over a decade about what is the best thing to do to prevent these types of healthcare-associated infections. Do we target the bug? Do we try to screen people, find out if they have it, and do something for those people? Or do we target populations? Do we go to high-risk areas like the intensive care unit and treat them all the same and try to prevent infections that way? And so this comes up over and over again, and the need for a definitive trial was quite prominent. So this trial was really a partnership between Hospital Corporation of America, which is the largest private health system in the United States, accounting for about 5% of all inpatient stays and having over 165 hospitals nationwide. And a group of academic researchers that were well-versed in healthcare-associated infection research and the conduct of clinical trials. And one of the things that I'll actually mention about the genesis of this is that we were quite fortunate that actually the Chief Medical Officer of Hospital Corporation of America and Rich Platt, the chair of the Department of Population Medicine at Harvard, were sitting next to one another in an IOM committee. And I'll talk a little bit about how that really spurs the ability to move these trials ahead. So briefly about this particular trial, it was a cluster randomized trial, which means we randomized hospitals, and all of their adult ICUs were assigned to the same strategy. So they're one of 3 strategies. The first one was standard care, which is screening everybody who comes into the ICU for this particular superbug by putting a swab in the nose, and then isolating them if they were known to be positive, putting them in a single room with gowns and gloves for all providers. The second arm was to do the exact same thing, except to now do something for those patients. And so those patients, in addition to being isolated, were actually given antiseptic soaps and an ointment in the nose to try to get rid of the superbug to prevent them from having disease. And the third arm was to say we're not going to target the organism at all. We're actually going to consider everybody in the ICU at high risk. We're not going to screen anybody, and we're going to give everybody the antiseptic soap, and we're going to give everybody the antibiotic ointment in the nose for a few days and to see whether or not this could produce a reduction in infections. The outcomes were looking at this particular superbug. Were we able to reduce it for the cultures that would come out during that ICU stay, and then secondarily looking at bloodstream infections, both due to that superbug and then due to all-cause bacteremia, because this particular antiseptic soap had broad application to all bacteria. So why is it important that we built this type of partnership? And I think that we were very fortunate that at the time this particular topic was and continues to be a very large national priority. So there was a synergy of both what the academics were interested in looking at and answering for the field, and a clear synergy with health system priority to try to reduce healthcare-associated infections. And this was made even more prominent by the fact that both state legislatures, so a lot of state laws were moving to public reporting for a variety of healthcare-associated infections, particularly in the intensive care unit setting. And of course, big payers like CMS were looking to add it into value-based purchasing. So because of all of those reasons, there was a nice movement towards trying to find the right answer. What is the best way to move ahead for best practice? And I'll say that there's a real value, I think, in the case for quality. And The other big component for the movement with the partnership with Hospital Corporation of America is the strong dedication that they have to quality. And there's a real nice example there. I've listed a Harvard Business Review article, but that's now moved into a book, and they've actually looked at thousands of companies and looked at the hundreds of them that have remained successful for the longest period of time, and found that one of the major rules is better before cheaper. The idea that you should move quality, the equality agenda first. And it's quite remarkable that John Perlin, as I remember the beginning of this partnership, said, don't slow us down. You know, you think of yourself as an academic partnership, you think the academics are at the cutting edge. And you know, his comment was related to his quality agenda, that a clinical trial shouldn't slow that piece down. I think the other strength of this particular trial was that, just like we know about human teams that work together to achieve a common goal, is that you need to cater to strengths. And it's not conceivable that each entity, whether it's an academic center or the health system, would do everything perfectly well in every part of what it takes to conduct a clinical trial. And so part of this was the absolute success that we had in looking at HCA's strength as a health system, understanding the priorities of the health system, the infrastructure of the health system, and absolutely their centralized data systems, as well as being able to command a very large number of hospitals. And then looking at the large academic partners that had experience in clinical trials and in coordination as well as design. I'll also highlight the fact that the Harvard Pilgrim Healthcare IRB was particularly instrumental because of their longstanding experience with quality improvement studies and their background in understanding what normally happens in health system, to be able to understand what would be the ethical foundation for deciding to rule on a quality improvement trial. And then we also had partners that were well-versed in resistance testing and microbiology to do some of these highly specialized testings for the bacterial isolates that we collected. And finally, we were very fortunate that the CDC Prevention Epicenters, which is an academic consortium of hospitals that are dedicated to reducing healthcare-associated infections through studies, including clinical trials, served as our steering committee. So some of our examples of collaborative successes that really would not have even been conceivably possible, if you think about it from an academic standpoint, is the speed at which we could recruit and achieve IRB approval. So in the course of this trial, we recruited 45 hospitals in 6 weeks' time, which is really a pace that it blew our minds as an academic group. And eventually 2 of those hospitals were excluded based upon exclusion criteria. The other thing, again, catering to strengths, is that HCA does not currently have a centralized IRB, but they have a very strong compliance officer. And through the partnership between that corporate compliance officer and the Harvard IRB, we were able to have a reliance agreement set up between the vast majority of those hospitals, so that within a month and a half, all IRBs were in hand. So an incredible speed from the start of this trial to the time we actually enrolled patients to receive the intervention. So there were a total of 74 adult ICUs in 43 hospitals across 16 states, and really pleased to say that 42 of the 43 were community hospitals, the real bread and butter of the way clinical care is conducted in the United States today. It was also a very swift trial. So if you look at that, there was a 12-month retrospective baseline period. So we reached back into their centralized data warehouse, pulled readily collectible, routinely available data, and then moved quickly into a brief phase-in period, and then a very, very rapid intervention period. Because of the size and scope of the hospitals that were participating, we could get an answer to this important question: do you target the bug, or do you target a high-risk group within effectively 18 months? This is a distribution of hospitals across the United States, very representative of the reach that HCA has. And then I'll mention that the design of this trial was also really important. It's very important that in the end of the day, you could say that when a trial is published, that those results are easily adoptable by other hospitals. The idea that they would believe that the way in which you conducted it is something that they could achieve at their local hospital, and therefore your results that you find would be representative of what they would find were they to adopt those interventions. And so this particular trial, we had no on-site investigators. We didn't parachute in people who had special expertise in research. We basically absolutely leveraged the existing quality improvement infrastructure of infection prevention, the normal way in which they roll out educational and other types of campaigns in those hospitals. We loaded them with all of the education and the protocols and the computer-based training modules that they needed, and we had coaching calls that occurred twice monthly. But effectively, their usual infrastructure is what made this particular trial possible. And finally, we used pragmatic outcomes, this idea that we weren't going to be delving into or forcing people to do very extensive chart reviews. We were going to use routinely collected data that existed in the electronic health record to actually determine the outcomes of this trial. And so those were readily available microbiology data in this case. And another very important part is that we didn't take possession of the data. So as an academic, a group of academic institutions, we didn't ask Hospital Corporation of America to give us the information for 43 hospitals for effectively 2.5 years worth of time. As you can imagine, that amount of data is something that would produce a large amount of risk for them, both for the privacy as well as the possible proprietary reasons for why they invest in certain types of hospitals for their system. So we actually reached back behind their firewall, did all of the analyses, and then only moved summary level data that they approved into our academic hands. So I'll say that it was a very large trial, as you can see, and the primary outcome was a really clear evidence that universal decolonization, the idea of targeting high-risk populations, everybody in the ICU, was actually the most effective strategy in reducing both MRSA clinical cultures and then in reducing bacteremia as well, with a whopping nearly 50% reduction in all-cause bacteremia from all pathogens. I'll also say that if you look at compliance, when you look at this idea of rolling out a pragmatic trial, what is achievable when you don't have investigators on site, that we were very fortunate that we actually had very clear separation between the arms. So you can see in Arm 1, routine care, there was very little use of these decolonizing agents. In Arm 2, again, this listed there just for those who had the superbug, you can see that the use was pretty high, 89 to 91% of the actual product. And then in Arm 3, universal use, 81 to 86% use of the soap and the antibiotic ointment. So in summary, this was an example of a very effective, rapid, and cost-efficient pragmatic trial. All told, compared to a lot of the other studies that have been published, particularly those involving drugs and devices, this trial cost came at a dollar amount of $40 per patient. This is in contrast to $10,000 or $20,000 per patient for a lot of the trials that have been previously presented. And also the intervention cost to actually implement after you have the answer is actually quite low, because this is basically swapping out bathing soap and adding a nasal ointment. And again, the speed at which this occurred was so fast that you couldn't even do an interim analysis if you wanted to. Unfortunately, for minimal risk reasons, we weren't required to. But this just shows the ability to really merge partnerships between a large healthcare system and academics, so that you are not waiting 10 years in the wings for an answer to a very important question. So a large benefit, as you can see, for reducing bloodstream infections and MRSA, and really across the trial, minimal adverse events for this minimal risk trial. And finally, a nice and definitive answer for the field after many years of waiting, that we believe that what we call horizontal or more universal approaches appear to work better in this setting for this outcome than targeting specific superbugs. So thank you.
Thank you very much. I think in the interest of time, we'll go through the other three speakers and then take questions and comments and open it up to the group. Thank you.